as you know, and to ER positive, HER2 negative early breast cancer is to standard of care is to primary surgery, and after that is to after chemotherapy and to endocrine therapy plus minus in the chemotherapy. So of course is to determine the to additional chemotherapy according to the to pathological and clinical factor and to additional is to gene factors, so and such as oncotype DX. But however, that is oncotype DX is to not standard among the all over the world because of the high cost. So and to neoadjuvant endocrine therapy is to very convenience is to tool that is so for and ER positive HER2 negative breast cancer. So but however is to neoadjuvant endocrine therapy is not standard is to standard of care because of the purpose is unclear is in the world. So and I conducted is two NEOS trials. Is two NEOS trial is two biggest is to the number of the enrollment is a neoadjuvant endocrine therapy, and this is to the purpose of NEOS trial is to is it possible to determine is to additional adjuvant chemotherapy is to after response guide is a neoadjuvant endocrine therapies. Primary analysis is to primary endpoint is progression disease-free survival. So and of course, in the 2 years ago is to already is to secondary analysis is data was published in the ESMO 2018. So, but is to neoadjuvant and adjuvant setting is a follow-up. It is very important to the long-term follow-up. So NEOS trial is was started is 13 years ago and 11 years ago. So now is to follow up over 7.8 years. So now is to enough is to event is to determine that is to primary endpoint disease-free as a disease-free survival. Now is to and this year the San Antonio Breast Cancer Symposium. I would like to determine there is to decision that to present that is to primary endpoint is this year the San Antonio Breast Cancer Symposium. So, and to disease-free survival is to, unfortunately, that is to not determine that is to the decision is to adjuvant chemotherapy according to only response guide neoadjuvant therapies. So, because that is so, and this study, NEOS study is randomized adjuvant chemotherapy plus endocrine therapy and the endocrine therapy alone is according to response guide to neoadjuvant therapy. Of course, is excluded is to progression disease is during neoadjuvant endocrine therapies. But is and to primary endpoint is disease-free survival is a trend is a better outcome in chemotherapy plus endocrine therapy compared with endocrine therapy alone. But however, is to primary endpoint is not met. So because is to hazard ratio is p-value is 0.1 and is so not met is to primary endpoint. Unfortunately, is to only response guide neoadjuvant endocrine therapy to it's very tough to determine that is adjuvant chemotherapy. But however, subgroup analysis is very important is to information was gained for investigators. So, and so low tumors, T1C and Ki67 is less than 20% is to population is endocrine therapy and the chemotherapy plus endocrine therapy, both is to no difference. Is a very similar outcome is disease-free survival. So I recommend that is neoadjuvant endocrine therapy is one of the standard of care for very small tumors, and to low differentiation is tumors, ER positive, HER2 negative population is recommended is a neoadjuvant endocrine therapy. And after that is to response guide is a neoadjuvant, and after surgery is it is decision is to additional chemotherapy without chemotherapies.